to talk about the Ledermix materials. Now, just before we get things underway, I do want to just make a little bit of a declaration. Firstly, I need to let everybody know that I do occasionally act as a scientific advisor for Austin, and they also do pay me for lectures on occasions, but they do not have any say in the material that I present, or they don't influence the lecture content in any way. Throughout the webinar, we will, no doubt, some of you may have some questions that come up. There will be an opportunity to submit questions later on in the session. I will bring this slide up again towards the end of the session with some instructions, but you will see there that you can either type a question in the designated field on your desktop, or if you're using a mobile device, you can click on the question mark and type your question, and they will then be submitted. So let's talk a bit about the Ledermix materials. And before we get into the sort of modern aspects of it, I just want to go over a little bit of the history, because the history is actually really important. Now, Ledermix paste was developed in 1960 by Professor Andre Schroeder, and it was commercially available as Ledermix paste, as we know the name now, since 1962. So we have almost 60 years of research and clinical use of this material. Ledermix cement was developed in 1962, a little bit after the paste. Now, the story with Ledermix goes back to the 1950s, really, because corticosteroids were interesting to practitioners back then, particularly to deal with pain, and obviously that's to do with inflammation. They were used in various aspects of dentistry. The first, in terms of endodontics, was to treat acute apical periodontitis, and that was done by flushing the canal with a solution of hydrocortisone. And Wilson reported that that provided very prompt relief of pain. The use of a corticosteroid and antibiotic mixture was reported in 1961 by Schroeder and Triaden, and they mentioned that the findings were that the sensitivity to percussion and swelling were reduced dramatically. Now, the idea of combining a corticosteroid and antibiotic was to overcome some fears at the time that the corticosteroid may have some systemic effects, and we'll come back to that in a little while. Following those two major findings, there are numerous reports, and they were clinical and histological reports by many different people, particularly regarding the treatment of apical periodontitis. And that was over the next few decades. There were clinical and histological studies done for pulpitis as well. And initially hydrocortisone was used, but Schroeder soon changed to triamcinolone, which was considered to be a more potent corticosteroid. He initially combined it with chloramphenicol as the antibiotic component, and also with xylocaine as a local anesthetic agent in an ointment base. The procedure, and these pictures are taken from Schroeder's textbook in 1981, the procedure really is not too different to what we would do today. We'd remove all the caries, and then he mixed a corticosteroid antibiotic paste that he had developed, and he placed that into, or mixed it into a cotton pledget, applied that over the exposed pulp, and then closed the cavity with a temporary restoration using zinc oxide and eugenol. A week later, he went back into the tooth to remove that pledget, and he replaced it with a hard-setting capping cement such as calcium hydroxide, and then restored the tooth. Now, initially they reported the outcomes for 200 teeth, and they reported that the pain disappeared within 2 to 3 hours, even when there was suppurative pulpitis, and the majority of the pulps remained healthy in the longer-term follow-ups. It was only those suppurative cases that needed further treatment in the form of root canal treatment, and that's actually quite important to note, because suppurative pulpitis really is telling us that we have moved from just an irreversible pulpitis to now having an infected pulp where there's pus being produced. So that to me would indicate that we have irreversible pulpitis progressing to necrosis. So in today's terms, we would not try to treat those teeth with a conservative treatment as they were doing back then, because it's unlikely to work. But where it was reversible pulpitis, then the pain disappeared very rapidly and the teeth recovered. So as I said, they initially were using the triamcinolone with chloramphenicol and xylocaine, but it was soon Schroeder realized that he didn't actually need the xylocaine, so it was just triamcinolone and chloramphenicol that he wanted to manufacture. But the company that he approached to produce this material, which was called Ledermix Pharmaceuticals, had developed another antibiotic called dimethylcycline or dimethylchlorotetracycline, which is a tetracycline drug, and they wanted to use that in this mixture that Schroeder was suggesting. And that's really the reason why dimethylcycline was used in the material rather than the chloramphenicol. As you see a little bit later, that was actually quite a fortunate change in formulation. So around that time, Schroeder said that if you want to do direct pulp capping, the materials that you use should be dentinogenic, so in other words, to produce dentine in the form of a dentine bridge. They should be antibacterial and anti-inflammatory. And no single material is likely to have all of those properties. And therefore, he came up with the idea of combining different materials to achieve those three properties all in one. So he used the corticosteroid antibiotic for the anti-inflammatory action of the corticosteroid, the antibacterial action of the antibiotic, and he combined it with calcium hydroxide for its properties that were well known in those days and still are for stimulating hard tissue formation, but also calcium hydroxide has excellent antibacterial activities. And then the zinc oxide eugenol was used to create the cement base, and the eugenol within that mixture has both anti-inflammatory and antibacterial action at different concentrations. So further, Schroeder said that the corticosteroid had two main goals. One was to prevent the acute exacerbation of tissue that is already inflamed. So if we're dealing with, say, either a chronic pulpitis or a chronic apical periodontitis, when we try to do some treatment, we can exacerbate that inflammation. And he also wanted to prevent the necrosis that was inevitably caused by calcium hydroxide, and I'll come back to that point in a little while. The zinc oxide eugenol doesn't affect calcium hydroxide, whereas zinc phosphate, which was commonly used back in those days, is acidic, and that may neutralize the calcium hydroxide and thus make it less effective. So he felt that the zinc oxide eugenol as a base, as a cement base, was much more appropriate. So Schroeder then moved on a little bit, and in order to try and simplify the treatment a little bit, he decided to mix equal volumes of the Ledermix paste that he developed with calcium hydroxide powder and apply that as a pulp cap after removing all the caries. And that really is the first use of what we now commonly call the 50-50 mixture. So he was using it as a pulp capping agent, and then he would place the zinc oxide eugenol as a hard setting base or a temporary filling over that capping agent, and then restore the tooth as required at the same appointment. Well, he followed those cases up and reported excellent results with very rapid pain relief, and over time the pulp survived when reviewed, and the reviews were done with pulp tests and radiographs to be sure that the pulps had survived. And this is some of the histological evidence that Schroeder presented. We can see there's no inflammation in the pulp, particularly under the area where the exposure had been. There is some tertiary dentine forming, such as in this case here, and these cases are taken from humans. So we really actually have excellent healing results with particularly the lack of inflammation in the pulps. Studies were also done in monkeys and showed the same types of healing responses. So histologically, excellent healing, clinically, excellent healing, and recovery in terms of pain. So the next step in the story was that Schroeder decided, well, instead of using this paste and mixing it with calcium hydroxide and then placing zinc oxide eugenol over the top of that, he decided to try combining them all into one material. So he used triamcinolone and dimethylcycline, but for some reason, I don't know what the reason was, he used those at a lower concentration than what he had in the paste. So 0.67% triamcinolone instead of 1%, and 2% dimethylcycline instead of 3%. And he combined them with zinc oxide eugenol and calcium hydroxide. And the rationale here was to avoid the need to have two appointments. So instead of going back into the tooth to remove the paste and then place something hard, combining all of these materials would achieve the desired therapeutic aims with one material, and a hard setting compound was much easier to use and you could restore it immediately. And that basically was the Ledermix cement. So that was born, we could say, out of that story there. So we had Ledermix paste and now Ledermix cement. But in those days, we're talking back in the 1960s, it was controversial. There was opposition from a lot of people, particularly in the United States of America. And there were a number of concerns that were raised. People were concerned about systemic side effects of corticosteroids. They thought the steroids would not be able to stimulate calcific repair, and that they'd lead to chronic inflammation and maybe pulp necrosis. They're also worried about the use of tetracycline, that we might have resistant microorganisms develop, that there might be hypersensitivity reactions to tetracyclines, and they thought that maybe there could be more specific antimicrobial agents available. I think it's actually important that we address these issues, and I still often hear today that Ledermix is banned in the United States of America. Well, that's actually not true. Sorry, just see if everybody's awake there. So it's never been banned. The real story, or the truth, is that Lederle Pharmaceuticals, who were making the materials back then, never submitted the Ledermix products to the American FDA system for approval. And that was based on a financial decision. And I had discussions with them back in 1994, and their attitude was that Ledermix was about a $500,000 product per year at that stage, whereas they were making other drugs which were worth billions of dollars. So they didn't want to invest a lot of money in the process to get the FDA approval, where they thought it was actually a fairly small market. So it was really a financial or commercial decision rather than anything else. It had nothing to do with the science behind it, despite me trying to persuade them that there actually would be a good market there if they were able to penetrate it. So let's address some of those concerns. The first one, systemic side effects of the corticosteroids. Well, I showed in 1992, where we analysed the release of corticosteroid from both the cement and the paste materials, that there was insufficient steroid amounts used in them anyway to have any systemic effect. But particularly when you think about how much of the corticosteroid comes out of the materials, and we compared that to the endogenous levels of steroids in humans under normal and stress conditions. So we're looking on the left here, we're looking at the endogenous cortisol in humans, about 20 to 30 milligrams per day, and that can go up to 300 to 400 milligrams per day under a stressful situation. Now, in terms of the potency, triamcinolone is about 5 times more potent than cortisol. And then if we look at the amount that comes out of the paste, firstly, the amount that's used in the paste is 76 milligrams, but what actually comes out of the paste is about 0.24 milligrams after the first day, and about 0.8 in terms of the cortisol equivalent. So you can see that it really doesn't calculate at all, that there's highly unlikely to be any systemic effect of corticosteroids from using Ledermix paste or cement in teeth. The next controversy was whether or not steroids would stimulate calcific repair. Now, I've already shown these slides before, and Schroeder reported that there was actually a mixture. Some cases did show some hard tissue formation over the exposure site, while other cases didn't. And the typical healing response from Ledermix cement has been actually investigated by many people over the years. And what we typically find is that there's normal pulp tissue in contact with the cement and no inflammatory cells within the pulp. Now, occasionally we will see diffuse calcifications in the pulp, and occasionally we will see a dentine bridge that forms. But the real question here is a dentine bridge really necessary? And as I said, mixed reports from histological studies, but it doesn't matter whether a dentine bridge forms or not. And in my view, no, it doesn't matter at all. It might make dentists feel good that we've stimulated some dentine to form, but that dentine bridge does nothing to actually help with the pulp or to protect the pulp or anything else, even in the long term. If there's a dentine bridge, I think many people believe that that might be a protective function to stop bacteria getting to the pulp, but that's not true. It doesn't have any protective function. Dentine itself doesn't. It's a porous substance with lots of tubules, and even if the bridge doesn't have the normal tubular structure, it is still also quite porous, so bacteria can get to the pulp whether or not there is a bridge there. So all the dentine bridge does is to tell us that the pulp's been irritated and stimulated, but it's not actually essential for the healing process. So as I said, it lacks the usual structure, and once the bacteria get to the dentine bridge, it's too late anyway because they're well and truly into the tooth. So that's not an issue. Now, the third point was that steroids could lead to chronic inflammation or pulp necrosis. Now, again, that's not supported by the clinical studies or the histological studies. We see normal pulps underneath the exposure site and where the material has been placed. How about the development of tetracycline-resistant microorganisms? Well, after 58 years of use of dimethylcycline in Ledermix, there have not been any reports in the literature of resistant microorganisms. We also need to consider what we're actually doing, particularly in using the paste during root canal treatment. The recommendation is not to use Ledermix as the sole dressing or medicament in a canal before doing the root canal filling. The recommendation, and I very strongly recommend this myself, is that you should use calcium hydroxide as a final dressing in all infected cases before you look at doing the root canal filling. And I'll come back to some of the reasons why a little bit later, because there are some limitations in terms of the effectiveness of the tetracycline, but that's not a reason not to use it. Calcium hydroxide has a much broader antibacterial spectrum of activity, and so if the dimethylcycline hasn't destroyed any bacteria, then it's highly likely that the calcium hydroxide will counteract that problem. The next concern was the possibility of hypersensitivity reactions to tetracyclines. Well, allergy to tetracycline is extremely rare in any case, and as far as Ledermix goes, there have only been 2 cases reported over the 58 years of use of the material. The first one was in 2013, which is just a letter to the editor. There's not a lot of detail in that, so I can't really talk about that too much. The second one was a case report, and I was involved in that particular report. And yes, we did confirm that the particular patient had allergy to tetracycline, and that was quite easily managed simply by removing Ledermix from the tooth. So yes, hypersensitivity reaction to dimethylcycline or to any tetracycline is a possibility, but it would be a possibility for any antibiotic that might be used in a paste that's placed in the tooth. The last point is that there might be more specific antimicrobial agents available, and that is certainly something to think about. And Effie Ehrman in 1981 stated that the inclusion of a tetracycline was most unfortunate. Now, I want you to keep that in mind because I'm going to come back and address that a little bit more later on. But back then, they believed that a bactericidal agent would be better than a bacteriostatic agent. But the reality is we don't have to kill all bacteria. As long as any surviving bacteria can't reproduce, so if the bacteriostatic agent has stopped that process, then they're not going to survive for very long anyway. Also, we should have other treatment strategies to change the environment within the root canal system to make it unfavourable for survival of any bacteria. And that's all the usual things we would do during routine root canal treatment, such as removing the entry point where bacteria are getting in, such as through caries or cracks or restorations. We would use other medicaments, such as calcium hydroxide, as I said before. Now, other antibiotics have been suggested and some have been tested, but none have been proven to be any better in the root canal system. And we have to recognise that all antibiotics will have a limited spectrum of antibacterial activity. And that's important because root canal infections are always a multi-species infection. So we have to be careful. And something else to consider is that resistance is more common with other antibiotics, largely because they're used for many conditions and not just dental conditions, but many medical situations, such as the penicillins or amoxicillin and so on. They are so commonly used these days that there are many resistant organisms. Also, things like penicillins certainly have a much higher rate of allergy, so they wouldn't be appropriate to use. So there's no perfect antibiotic by any means. But as I said before, you should not rely on just one medicament during root canal treatment of infected cases. And once again, calcium hydroxide is something that we should use because of its very broad antibacterial spectrum and some of its other properties. Now, as I said, Evian said that inclusion of tetracycline was most unfortunate, but actually in subsequent studies, particularly those looking at external inflammatory resorption, typically following trauma, was actually shown that the choice of a tetracycline was actually very fortunate. And that's because we now know that tetracyclines have the ability to inhibit clastic cells, so the cells that are resolving the tooth structures, cementoclasts, dentinoclasts, and probably also osteoclasts. And so for the management of external inflammatory resorption and also internal inflammatory resorption, the use of a material such as Ledermix is advocated because we actually have two agents that are working to inhibit the plastic cells, so the tetracycline, but also the corticosteroid. And we'll come back to that in a bit more detail in a little while. So although the use of a tetracycline was thought to be unfortunate when it was first produced, it did actually turn out to be quite a fortunate situation. And it all comes back to, as I said before, the decision by the company making it to use their particular antibiotic rather than the one that Schroeder advocated. So none of those concerns that we've been talking about back in the 1960s and even well into the 70s and 80s, none of them were valid back then, and they're still not valid today. So I don't think we need to be concerned about using these types of materials at all. Let's just talk a little bit about Ledermix cement. Now, on the screen there, you'll see the major components. So the triamcinolone, as we said before, in a concentration of 0.67% of the powder. The dimetrocycline is 2% of the powder. And many people don't realise that Ledermix cement contains, or the powder contains 33% calcium hydroxide, and then about half of it is made up of zinc oxide, and then the liquid is mainly eugenol. So the zinc oxide eugenol gives us the hard-setting cement when it's mixed, and effectively what we've got is, although we tend to refer to it as a corticosteroid antibiotic compound, it's really a corticosteroid antibiotic calcium hydroxide zinc oxide eugenol compound. One could argue that the dimetrocycline is really not necessary in the cement, but that's there. We don't have any choice there. That's the way it's manufactured and doesn't do any harm and may do some good. I'm not too sure. In terms of how this material works, well, triamcinolone is a very powerful anti-inflammatory agent. And studies done by Rory Hume and Adriana Kenny back in 1981 showed that 70% of the corticosteroid is released from the cement by the end of the first day. So in this experiment, they had extracted teeth and they placed the material in there, and then they sort of analysed the release and diffusion of the material through the dentine. So you see on the graph there that by the end of the first day, 70% had been released, and by the end of the third day, the rest of the material had been released. So using this in vitro, we need to think it's probably slower in terms of release and diffusion than if it was used in vivo, so in a tooth where we have an active blood flow, and so we have the whole dynamics of diffusion and clearance of the drug once it reaches the pulp. So I would expect that the material will act faster and for a much shorter period of time than what we see in the in vitro study. So some of the concerns that people have about using Ledermix cement is that it can cause the pulps to die. Well, we've already said it doesn't do that, but one of the reasons why it doesn't do that is because triamcinolone is only there for that very, very short period of time. So there's no evidence that it causes pulp necrosis without symptoms, which is something that I keep hearing people say. If pulp necrosis does occur, then it's not because of the Ledermix cement or the corticosteroid in it, it's because the pulp wasn't healthy enough to survive. In other words, it must have been irreversible pulpitis rather than reversible pulpitis. So we have to be very clear and careful when we make our diagnosis that we're actually using this material in the appropriate situation. So in other words, reversible pulpitis. So we need to overcome the sort of long-held misconception about Ledermix cement, and it really arose from a lot of inappropriate use and probably a lack of diagnosis and a poor understanding of the disease processes, as well as a poor understanding of the pharmacodynamics of corticosteroids and misconceptions about the corticosteroids and really, I think, unrealistic expectations of the material. So I'm talking back in the 1960s, 1970s, even into the 1980s, when dentistry was different. We didn't have the understanding of the disease processes that we have today, didn't have the understanding of the drugs and materials that we have today. Diagnosis wasn't such a big deal back then. Patient would come in with pain, dentists were doing or trying to do the right thing by saving the teeth. And here was this material where they were confident they could place it in the tooth and would get rid of pain, but then subsequently found in some cases, maybe a couple of years later, that the patient had developed apical periodontitis because the pulp and necrose had become infected. But that was going to happen if you did it in the wrong situation, as I said, with, say, irreversible pulpitis. So what we should think about as Ledermix cement is we have a corticosteroid that has a very short-term effect, maybe 1 to 3 days maximum, and then it's all gone. After that, we'll still have some antibiotic there, but as I said, that's probably not doing anything. And we have a calcium hydroxide, zinc oxide eugenol compound. Calcium hydroxide can promote dentine repair, and many, many studies in the literature about that. And then the eugenol component of the material is anti-inflammatory and also antibacterial, just depending on what the concentration is. So we have almost a perfect material in many ways. And here's some examples of typical healing response, where we see a pulp that is quite healthy underneath the material where it's been exposed. There's no dentine bridge in that particular case, and there's no calcification throughout the canal. In the other example on the right, there is some calcific material here in the form of a dentine bridge, and there are some diffuse calcifications occurring down into the root canal. So in some cases, as we said before, we may get hard tissue forming, but not in all cases, but we don't need it. Here's another example from Barker and Ehrman's work, again showing inflammation-free pulp underneath the Ledermix cement pulpotomy. If we compare that to the typical healing response we see with calcium hydroxide, and this is from Schroeder's work, and with calcium hydroxide, because of the nature of the material, it's actually toxic to some extent due to its high pH, and that's good in terms of killing bacteria, but it can also kill mammalian cells, so our cells. And so typically what we see is a layer of necrotic tissue underneath the calcium hydroxide, and then you see this calcified tissue, and then there's a dentine bridge that can form. And many studies, particularly by Schroeder and Sveck and others like that, have shown this is the typical response that occurs. So if you were to examine these teeth later on, so histologically here you see the same sort of thing. The necrotic tissue layer has disappeared in this case under the histology, same here. And then we have this dentine bridge forming. And so when you go into these teeth clinically, and I'm sure many of you have seen this, we go into a tooth where there's been a previous pulp cap and you remove that final bit of material and it's like there's a hole there. And then if you probe underneath there, you'll find that the dentine bridge with hard tissue. So that's typically what happens with calcium hydroxide, but it doesn't happen with Ledermix. And so that's why there's some advantages there. You're not left with that little defect there. Now, I talked about the release and diffusion as shown by Hume and Kenny, and a project that I published a few years ago now, where we looked at cracked teeth with reversible pulpitis. Now, it's important to understand the diagnosis here is reversible pulpitis. We used Ledermix cement and followed the teeth up for a number of years to see what sort of response we got. And a really interesting thing here was in the 85 teeth where we placed Ledermix cement after removing the caries and the cracks and the old restorations, 71% of those patients reported that they had no pain even from the time the local anaesthetic wore off. No more pain, whereas prior to treatment, they did have pain. 21% said by the end of the first day they had no more pain, and then there was a small number that took 2 or 3 days for the pain to go away. So that immediate relief of pain and up to the end of the first day is very consistent with what I was saying before about the release of the corticosteroid in the in vivo situation is going to be a little bit faster than it was in the in vitro studies. So here we have a clinical study that actually is quite consistent with the laboratory study. So again, it's telling us that the corticosteroid works very quickly and for a very short period of time. Now, of those 85 teeth that were managed conservatively with that Ledermix cement and a glass on an interim restoration, 94% of those pulps recovered. There was one tooth, so just over 1%, where the pulpitis continued. So that was either a case of the diagnosis wasn't quite correct, must have been irreversible pulpitis, or perhaps by doing the procedure we may have converted the reversible pulpitis into irreversible pulpitis. There was one tooth that had pulp necrosis evident after the 3-month review, and one tooth where we weren't sure of the pulp status, and unfortunately the patient didn't come back after that. And then there were 2 teeth where pulpitis developed again after the patients had been sent back to their dentist. Once we confirmed survival of the pulp, sent them back to their dentist to have the tooth restored. And in these 2 teeth, once more operative treatment was done to the tooth, the pulpitis occurred again, which would indicate that the pulps weren't entirely healthy. But basically, we had 94% of the cases where the pulps recovered, and those teeth were reviewed for up to 5 years. So I think Ledermix cement is certainly a material that can work extremely well for pulp capping. That could be indirect or direct pulp capping, also partial pulpotomy, and for a full pulpotomy. And here on the screen, there's an example of a patient who had trauma, and one tooth we had to do root canal treatment. And so the tooth I want you to look at, though, is the other tooth, the 1-1, where a partial pulpotomy using the SPEC technique was done, but with Ledermix cement as the capping material. Now we can see a 3-year follow-up where everything is quite normal and the pulp has recovered and the root has continued to develop normally. Now, it's not just anterior teeth. This can be done on posterior teeth, basically any tooth where a pulpotomy or a pulp cap may be required. And here we see an example of a posterior tooth, lower first molar. And when you look at the 1-year review and compare the stage of root development on both roots to the preoperative view, we would have to conclude that the pulp has survived because the root has continued to develop and the root canal system has narrowed down. So with conservative pulp treatments, there are obviously different materials that we can use. Corticosteroid antibiotic compounds such as Ledermix cement are my first choice of material. You could use calcium hydroxide, or you could use one of the bioceramic materials such as MTA or biodentine. But to me, the advantages of the corticosteroid antibiotic compound is that we're actually addressing the problem that the patient comes in with. So it's an inflammatory condition, so our corticosteroid can help to reduce the inflammation. It has a very short-term use, as we showed. It then becomes essentially a calcium hydroxide, zinc oxide eugenol compound, so we're getting the benefits of calcium hydroxide without the disadvantages of that necrotic layer of tissue that calcium hydroxide forms. So in many ways, I believe the Ledermix cement is the ideal the ideal material for conservative pulp treatment. So that could be indirect or direct pulp capping, partial pulpotomy, or a full pulpotomy. And the reason it's meeting the 3 criteria that Schroeder described for these treatments. So it's anti-inflammatory, it's antibacterial, and it's dentinogenic because of the constituents of the material. And some of them can have, some of the functions we need can come from more than one of the components there. So we've been talking about Ledermix cement. Let's switch now and talk a little bit about Ledermix paste. And this particular case has the 2 sorts of situations where Ledermix cement would be Ledermix paste is a material that we could consider to use. So in the second molar, the 3.7, we have acute irreversible pulpitis, and in the first molar, we have a pulpous and infected root canal system with chronic apical periodontitis. So we have inflammatory conditions, with one inside the root canal system, in the pulp. The other one, we have an inflammatory condition in the tissues surrounding the tooth root as a result of bacteria in the canal. So Ledermix paste is made up of 1% triamcinolone and 3% is dimethylcycline. The rest of the paste is a water-soluble paste. One of the major components is PEG, or polyethylene glycol, and that gives the paste consistency that we're all familiar with from our clinical use. Now, I've been involved in research on this material over a long time now, as David said in the introduction, and in the early days when I was interested in this, we wanted to work out how did the material work. And so basically when you put something inside the root canal system, it can, in the form of a paste, it can release its components. And so the active components being the corticosteroid and the antibiotic, they can be active within the main root canal itself. So say if there are bacteria in there, then the antibiotic could work on those bacteria. Or if there's still some inflamed pulp tissue in the canal, then the corticosteroids can act on that. The dentine is a porous object, so it's made up of tens of thousands of tubules per square millimetre, depending on what part of the tooth you're talking about. So those tubules are pathways for the molecules to diffuse through the dentine, and they can then reach the periradicular tissues, or they can diffuse through the apical foramen or lateral canals to reach the periapical tissues. So the material has several places where it can work. As I said, one is within the canal. Secondly, it can be within the dentine itself, and then also in the tissues surrounding the tooth. And that's a real advantage. Now, all those studies I showed a couple of slides ago can be summarized with this very simple graphic representation here of what happens. So when you place the material in the canal, there's a very rapid release of both the corticosteroid and the antibiotic. So most of it is being released within the first day and up to about a week. And this is a lot on the lower axis. And apologies for that phone call. So there's a very rapid release, and then it tapers off over a period of time. And by the time we get to 3 months, there's really no more release coming through. And we, by testing at different times, particularly in fully developed roots, we found that by 6 weeks, we really don't have therapeutic amounts coming through to the surrounding tissues anymore. So that's important to know, because if we place Ledermix paste in the root canal system, then by 6 weeks, we're not expecting it to have much effect anymore. If it's a very young tooth, so an immature tooth where tubules are wider, then it loses its activity or the therapeutic amounts by about 4 weeks. So in those teeth, you would need to change your dressing on a more regular basis. Now, the triamcinolone, as I said before, if there's any pulp tissue left in the canal, it can work on reducing inflammation in that tissue. And so that can be very useful, say, in the emergency management of acute irreversible pulpitis, where you may not have time to completely clean the canal and enlarge it. The other situation where we want it to work is either periapically, such as when we have apical periodontitis, and if we have inflammatory resorption, then that's typically going to be either apically or on the lateral part of the tooth root. Then the corticosteroid can work in that area there to inhibit the clastic cells and reduce inflammation. Now, in our diffusion studies, we were able to measure the concentration of the corticosteroid in a solution bathing the tooth, and it's only a very, very small amount, as we said earlier on when we were talking about systemic side effects. It's in the nanomolar range. Fortunately, that's sufficient for anti-inflammatory action. So it's almost a perfect drug delivery system. With the dimethylcycline, we don't need it, we don't really want it to be in the tissues surrounding the tooth. Where we want it is in the dentine. Now again, in the main canal itself, it can work directly on bacteria there, but by diffusing through the dentine, it can target any bacteria that are in the dentinal tubules. And we see there that there's a concentration gradient as we go from the canal out towards the cementum. It drops down, and after a week, it's 10 times less there. So most of the action is happening within the first day or so. So why do we use medicaments? Well, one reason is for its antibacterial action. I want to come back to this, but that's one of the reasons why Ledermix is a good material to use. The other reasons are all associated with inflammation and pain and repair and inflammatory resorption. So again, all related to inflammation. And as I said, we'll come back to the antibacterial action, but let's address the inflammation and pain aspects first. And this was an excellent study out of the University of Melbourne in 2003, where a number of teeth with infected root canals and acute apical periodontitis were treated in a sort of standard mechanical way in terms of instrumenting the canals to their full length. And then some teeth were medicated with Ledermix, some with calcium hydroxide, and some were left without addressing at all. And patients were asked to score their level of pain both before and after the treatment over the next few days. Now, the people in the study reported that there was significantly less post-operative pain in the Ledermix group compared to the other two groups. And the calcium hydroxide and the control group were pretty much the same. There was no statistical difference. The Ledermix is the lower line here, and on the vertical axis, we're talking about the reduction in the pain score. So the other interesting thing was that the Ledermix group, just by chance, started with a higher average preoperative pain score. And the greatest effect was noted at the 4-hour post-operative interval, where the pain level was well below the other groups, and then it remained below them over the subsequent 4 days. So here we see the chart there. And if we blow up this area here, we'll see that the Ledermix started much higher than the other two, but dropped down very rapidly, as I said, at that first, or the 4-hour pain score that was taken. Now, they concluded that Ledermix paste is an effective intracanal medicament for the control of post-operative pain associated with acute apical periodontitis. But one of the really interesting statements they made was that the rapidity of action of the medicament with corticosteroid was striking. So in other words, the pain relief was very, very rapid. So it's a good material to use when you have a patient with acute apical periodontitis in particular. Now, I've mentioned inflammatory resorption a couple of times, and the work on this goes back to Angela Pierce from Adelaide and Sven Lindskog from Sweden. And in this particular study, which was done in monkeys, they had an avulse tooth model where teeth were extracted and left dry on the bench for an hour before they were replanted. And in one group, there was no medicament placed in the tooth. And we see here that 89% of the root surfaces had inflammatory resorption, 8% had inflammation in the PDL, so that's pretty much the entire root surfaces involved with inflammation and resorption. Whereas in the Ledermix group, there was no inflammatory resorption and no inflammation in the PDL. So a striking difference between the two groups when it comes to reducing inflammation and inflammatory resorption. Now, there was some surface resorption in the Ledermix group, none in the other group, but that's because the other group had all progressed to become inflammatory resorption. And you might notice that there was a lot of ankylosis in the Ledermix group, but that's because the teeth were left dry for an hour before replanting. So we're not talking about trying to stop replacement resorption, but the Ledermix could stop the inflammatory resorption. And here you just see a comparison of sample teeth roots from each group. So one on the left, there's some intense inflammatory reaction and resorption going on in all those dark areas, whereas the Ledermix group, there's no sign of any inflammatory resorption. There is some ankylosis and replacement resorption happening here, but as I said, no inflammation and no inflammatory resorption. Now, they've also, Peter Lindskog, along with Jeff Hethersay from Adelaide, looked at how this might work, and they looked at dentin class from rat teeth that were undergoing inflammatory resorption, and they exposed them to either the antibiotic or the entire Ledermix paste. and the entire paste was more effective in that the cells weren't spreading, and there weren't any dentin class evident after 18 hours. Whereas if it was just exposed to the dimethylcycline, there was still some attachment, and cells will spread after 24 hours. So as I said before, the dimethylcycline has some effect on the clastic cells, but it's largely the corticosteroid that has the more anti-resorptive activity. And that's consistent with studies that have been done on using corticosteroids for bone resorption. Having said that, the antibiotic component does contribute to the therapeutic effect, partly by inhibiting clastic cells, but also importantly by eliminating or killing any bacteria that are left within the root canal and the dentine tubules. Now, as I said before, the use of tetracycline is quite fortunate, but it wasn't known back in 1962. But subsequently, we know that tetracyclines can be used to modulate host responses, such as inhibiting the osteoclasts, and we have the effect of binding to bone and teeth. So when we place it in a tooth, there's the slow release, as I showed you before, and the dimethylcycline binds with the dentine, and so it actually stays in the tooth for a longer period of time. So the diffusion of the tetracycline is much slower than it is for the triamcinolone. Now, these studies are all consistent with other studies. Firstly, using tetracyclines, Martin Trope's group has shown that inflammatory resorption model in dogs, that the tetracycline is better than amoxicillin in controls for inflammatory resorption, but also for replacement resorption. So there is some evidence. It's not a lot of evidence, but it can also help to slow down replacement resorption. And SVEC has also shown the effect of doxycycline in reducing ankylosis, replacement resorption, and inflammatory resorption. They're also consistent with studies looking at corticosteroids. And again, Trope's group with Salim showed corticosteroids in a replacement resorption model were better than things like tissue culture medium, and better to use it topically than systemically. And Chen, again in Trope's group, showed that if you do immediate root canal treatment, triamcinolone was better than tetracycline alone, but using the combination within Ledermix paste was better overall results. And again, that was in a dog model. Now, further dog model is one that, again, Martin Trope's group that I was involved in, where we placed either calcium hydroxide or Ledermix paste into an avulse tooth model as soon as the teeth had been replanted, and then they were examined histologically after 4 months. And in that study, we found with the Ledermix group, 59% of the root surface had no resorption, compared to 14% with calcium hydroxide. And so the opposite there, that 41% of the Ledermix group had some resorption and could be inflammatory or replacement, whereas calcium hydroxide was 86%. And when we calculated the residual root mass, you can see the difference there, and they were statistically significantly different across all three of those measurements. So we concluded in that study that if you treat teeth immediately after replantation, so an avulse tooth, replant it, and immediately commence root canal treatment and place Ledermix paste in the canal, you'll have significantly more healing, significantly less resorption, and you'll maintain significantly more residual root mass than if you were to use calcium hydroxide. Now, I mentioned the antibacterial action of medicaments, so I just want to address that a little bit, because that is a little bit of a limitation of Ledermix paste. If we look at the minimal inhibitory concentration values for the common bacteria that we find in infected root canal systems, and compare that data to what I showed you before in terms of the amount of dimethylcycline within the dentine at various levels, we find that it's only in the dentine immediately adjacent to the root canal system where we are consistently above the minimal inhibitory concentration required for those common, or the two bacteria at the top of the list of common ones. Further out in the dentine, it's not as effective, and particularly if we look at after a week or so. So there are some limitations. We don't have a perfect material, but we do have excellent levels of the antibiotic within the main canal and reasonable levels immediately adjacent to the canal but reducing as we get further out. So as I said, we don't have an ideal material, but we have something that is pretty good at what it does. And if we remember that the antibacterial is limited, and if we try to grade it, and this is based on some other work we've done, Ledermix paste by itself would have the least antibacterial effectiveness. Ledermix mixed with calcium hydroxide is better, but the best antibacterial action comes from calcium hydroxide when it's used by itself. Now, that's not to say it's a problem with Ledermix. We just have to understand that and use it appropriately. And if you want some more detailed guidelines, these are older papers, but I think the guidelines are still actually quite relevant. So when we are thinking about what medicament to use, we really have three choices. We can use a corticosteroid antibiotic, such as Ledermix. We can use calcium hydroxide, and there are various forms of that, such as Calicet paste, Calicet Plus, or Calmix is another relatively new one. But we also have the option of combining the two, just as Schroeder advocated almost 60 years ago in a 50-50 mixture. What we need to think about is, what do we want from our medicament? So in other words, what's the diagnosis and what's the aim of the treatment? So if we have an inflammatory situation, such as irreversible pulpitis or acute apical periodontitis, then the most logical medicament to use, particularly as the first medicament, would be one with an anti-inflammatory agent. In other words, with a corticosteroid, so something such as Ledermix paste. If we want antibacterial action, so say if we have a root-filled and infected root canal system, or a pulpous and infected root canal system, then we can use either Ledermix paste or calcium hydroxide. They both have antibacterial action. But remember, Ledermix paste has some limitations with that, and so we might want to actually stage our treatment and either use the two together and then calcium hydroxide by itself, or if you need to use the Ledermix first because there's an acute apical periodontitis, then again you need to follow up with calcium hydroxide subsequently. And if we want to stimulate hard tissue repair, such as where we have an open apex, we want apexification, then once we've controlled the inflammation and the infection, then calcium hydroxide would be the material of choice to get that hard tissue repair before we do our root canal filling. So I mentioned the 50-50 mixture a couple of times, and as I said, it was originally used by Schroeder in a number of publications. He's talked about that. It was advocated in the 1980s by Jeff Hethersay from Adelaide, and I've been promoting it for many years also. Why do we do this? Well, there's a number of research papers that have been done. This is by no means a complete list of them all, but there are many others. Basically, what we've found through all those papers is that when we mix them, we have a slower release of the Ledermix paste components that can keep them in the tooth for longer, can maintain that sterility of the canal for a longer period of time. There's no change in the activity of the components. There's an increased antibacterial spectrum compared to using Ledermix paste alone, as I said just a few minutes ago. There's just a small reduction in the pH levels that we reach in dentine, so pH coming from the calcium hydroxide component. And we lower the tissue toxicity, and that's particularly associated with calcium hydroxide, and that's through the effect of the corticosteroid. So there are a number of advantages in combining them together. Often I get asked, how do we do that? Well, you can do it in a couple of ways, depending on what type of calcium hydroxide you use. So if you're using a saline-based calcium hydroxide, such as Calicet Plus, my recommendation would be to mix approximately equal amounts of the calcium hydroxide and Ledermix on a glass slab, and then place it in the canal in the normal way. I typically would use a spiral filler, or if I haven't prepared the canal, I'll just use a file. But if you're using a methyl cellulose or a PEG-based calcium hydroxide, such as Pulp or Calmix, when you mix them together, the mixture goes a bit gluggy, and so it doesn't spin down the canal very well. So in that case, I would place the Ledermix in the canal first, using, say, the spiral filler, and then I would place the calcium hydroxide in the canal, again with the spiral filler, so you effectively mix it in the canal. Now I'll just pause for a minute before I wrap up, just to show you the way to ask questions if you want, either by typing, if you're using a computer, typing a question in the designated field on the screen, or if you're using a mobile device, you click on the question mark and then type your question in there. I'm also happy to answer questions by email afterwards. Hopefully I can do that in a reasonable time, depending on how many people do send emails, but my email address is there on the screen, and I'll show that again a little bit later. So my typical treatment approach then, just to wrap up things here, when we're doing root canal treatment, my first appointment is all about the consultation, the diagnosis. We investigate the tooth, get rid of the caries and the cracks and the old restorations. We find the canals and negotiate them. I'll medicate them, and then I'll build up an interim restoration. About 4 to 6 weeks later, I'll basically do my root canal preparation, and then I'll medicate the canals again. And then about 4 to 6 weeks later, I'll do the root canal filling. So what do I medicate with those different stages? Well, it depends on the diagnosis. So if it's irreversible pulpitis, or a very, very rare occasion where I might do an elective treatment, my initial dressing will be Ledermix paste. If we just talk about irreversible pulpitis, we're dealing with an inflammatory condition. It's not infection, so Ledermix paste is the ideal thing to use. At the second appointment, after preparing the canals, I will introduce calcium hydroxide, and that's a little bit of insurance in many ways, just to make sure there are no bacteria that are there, because some pulps, when there's pulpitis, may actually contain bacteria, even though it's not infection, but they can contain bacteria. If, on the other hand, I'm treating an infected canal with apical periodontitis, then my first medicament will be the 50-50 mixture. So I want anti-inflammatory action, and I want antibacterial action, and I can get that from the Ledermix, and I can get it from the calcium hydroxide. But remember, the best antibacterial action is when you use calcium hydroxide alone. So the second dressing I use will be calcium hydroxide by itself. So just to summarise, Ledermix materials have been used and used extremely successfully now for almost 60 years. There's significant scientific research that supports the use, and that's a whole range of things: clinical studies, radiographic studies, histological studies in animals and in humans. The major function of using Ledermix, whether it's Ledermix cement or Ledermix paste, is its anti-inflammatory action through the triamcinolone. The second function is to reduce or to prevent resorption, and particularly inflammatory resorption. And the third function is its antibacterial action. There are many misconceptions and perceptions, but it's time for anybody that's a bit anti, I think, to move on. As I said earlier on, there are all these concerns that were there in the 1960s were not valid then, and they're still not valid today. So I hope that's given you a bit of a brief. I know we've had limited time to discuss it there. There is a lot in the literature if you want to go and look at it, but I would certainly encourage you to consider using Ledermix paste and Ledermix cement, because they are really good materials, and your patients will appreciate it if you do. So thank you very much for your attention. We will have questions for a little while now, so please feel free to send your questions in whenever you can. The question has just come as, why was it not available in Australia for a few years? Yes, that's an interesting question, but basically there was a supply problem. The manufacturers of the material overseas had problems in getting the dimethylcycline component, and so they decided to stop making it. But fortunately, Ausdent in Australia took it on board and started manufacturing it, because it was being made in a new factory under different circumstances. And even though it was exactly the same formula as the original Ledermix, the TGA wanted the whole process of registration to occur. And so that's a fairly detailed process and took quite a bit of time. But fortunately, we got it through, and it's now being used. The question then, is Ledermix cement radiolucent or radiopaque? It's slightly radiopaque, but once you put it under another restoration, it's fairly difficult to see. So, for instance, if you place Ledermix cement, and it's a very thin layer too, remember, you're not going to see it when you have the other material over the top of it. Next question, what about discoloration of the tooth using Ledermix? Well, we'll just talk about Ledermix paste, because Ledermix cement hasn't been shown to discolour a tooth, and again, there's only a tiny amount used. Discoloration can certainly occur with Ledermix paste, there's no doubt about that, but a lot of the work we've been doing, and particularly through Basil Athanasiadis up in Brisbane, has shown that the discoloration is really a result of the way you use it. So if you leave any of the material of the paste in the coronal part of the tooth, so inside the access cavity, you will get discoloration. Because discoloration with tetracyclines is a result of light, and particularly sunlight. So often, if we say where we might see discoloration is anterior teeth, they're going to be exposed to sunlight. And moisture is the other thing. So if you don't have adequate temporary restorations or other restorations in the tooth, then discoloration can occur just through moisture from the mouth getting into the tooth and leading to that discoloration. So in many ways, you could say if discoloration occurs, it's because of the way the material was used rather than because of the material itself. So you need to be very careful about how you use it. Another question's come through about, would calcium hydroxide reduce the effectiveness of the corticosteroid? We don't believe that is the case. There's no evidence that's been shown that that happens. And certainly there's no clinical evidence. And we only need to look at the results of the use of Ledermix cement. I think it's a particularly good example of why or how calcium hydroxide doesn't affect the corticosteroid, because pulps are still recovering once that material is used, and 33% of the cement, remember, is calcium hydroxide. So I don't believe that combining them is a problem. The next question is, how would you manage concerns from a pregnant patient regarding the safety of Ledermix for the fetus? Well, that's actually very easy, and I'd refer you to my study that I showed earlier on, where we looked at the amounts of corticosteroid coming out of the tooth in both the cement and paste situations. There's just simply not enough to cause any problems. And tetracycline is even slower in release because of the binding with the tooth. So the amount of tetracycline that actually would come out into the circulation is extremely small, and so we wouldn't expect to have any concerns with that at all. Julian has asked, what's the opinion on using odontopaste over Ledermix paste? Well, that's a tricky question. I think I base my choice of materials on the scientific literature, and I think that the literature contains a lot of scientific evidence for the use of Ledermix, whereas odontopaste has not been well researched over the years since it's been available. The other thing about odontopaste is it contains a different antibiotic, that's clindamycin, and that antibiotic is not like dimethylcycline in terms of its anti-resorptive activity, so the inhibition of clastic cells. So I think there are advantages in using the Ledermix because of that reason, particularly in trauma cases, but even in infected root canal systems where you have a long-term infected root canal system. In some studies, and particularly when I was involved with Ram Nair from Switzerland, we showed that 4 out of every 5 teeth with an infected root canal system and chronic apical periodontitis actually had external apical inflammatory resorption to varying degrees. But basically what we would say there is that when you have a tooth that has an infected canal and there's a periapical radiolucency, it's highly likely that you have some external inflammatory resorption. And so that's another reason to use Ledermix, particularly as your initial dressing. As I say, we've combined that often with calcium hydroxide in that situation. I think there's advantages in trying to use the Ledermix because we know of its effect. There's another question on Ledermix staining teeth, and if so, is there a way to overcome it or limit it? Yes, again, as I said before, keep the paste in the canal, keep the access cavity absolutely clean of any Ledermix paste. If you do happen to get some in there, clean it out before you place your temporary restoration. If by chance you still do get some discoloration, then it's very simple to bleach the tooth with internal bleaching once you've completed the root canal filling. So that type of discoloration is actually quite easy to remove. The next question is, what's the rationale behind the 4 to 6 weeks wait between appointments? The 4 to 6 weeks is based on a couple of things. If you're using Ledermix, I think you need a minimum of 4 weeks. 6 weeks would tend to be the maximum, although if you left it for 6 weeks, it just means that it's not really having much effect anymore. But it's also based on healing. You know, periodontal ligament and bone take time to heal, and that's what we're really trying to achieve, is healing of the surrounding tissues. So if you were to start treatment today and you see the patient next week, you still have inflammation in the periodontal tissues. Inflammation in soft tissue takes 10 to 14 days. In the hard tissue, such as bone, it takes even longer. So I like my patients to be completely comfortable before I do the next procedure, which may be the instrumentation or maybe the root filling. Because when I go back in and do my procedure, I will actually be causing some inflammation. So if it's already inflamed, I'm going to exacerbate that inflammation. If the initial healing has happened and it's not inflamed, then there will still be some inflammation, but it's not going to be as severe, and so it's not going to be as painful afterwards. Another aspect about the 4 to 6 weeks is when we talk about calcium hydroxide, it takes at least 3 to 4 weeks for the maximum pH to be reached in the what we call the outer dentine, so the dentine out near the cementum. So if you only leave calcium hydroxide in a tooth for, say, a week, it may be effective in the main canal, but the main canal is the easy part to deal with. The main canal is not the issue. The real issue is the dentine tubules, because that's where bacteria can be trapped. So as I said, you need at least 3 to 4 weeks. 6 weeks is just really giving it plenty of time to work, and the longer term exposure of bacteria to an antibacterial agent, the more chance that they won't survive. There's a question then, very similar. What do you think of root canal therapy of 2 weeks course of non-infected tooth or elective RCT? Again, it comes down to inflammation. 2 weeks would be the bare minimum. I would rather leave it longer to get more healing. And same with an elective situation. You're creating inflammation. When you sever the pulp at the apical foramen, you will create inflammation. And one of the things that I didn't get time to talk about tonight, which is actually a really important issue, is we will often, or not often, but probably more often than we would like, we see cases of neuropathic pain following root canal treatment. Now, that will normally happen after treating irreversible pulpitis or when you remove a normal pulp, because you're actually severing the nerves that go into the pulp. And I won't try to give a detailed explanation of that, but essentially what happens is that we get a nerve sprouting, and so you have multiple nerve endings that are firing lots of signals off back to the brain, and that can be interpreted as pain by the patient. So neuropathic pain in that situation can be really difficult to get rid of. But one of the studies by Rex Holland from the States showed that if you, and this was in animals, if they gave systemic corticosteroids, it drastically reduced the amount of the nerve sprouting, and so the expectation then is that it would reduce the amount of neuropathic pain that would occur afterwards. And so there's a lot of advantage in using the corticosteroid in the canal as an inter-appointment dressing, because you're placing the steroid almost at the site where you want it to work, in other words, periapically, and we know that it will be released from the paste and can diffuse through to that site where you want it to work. So it's like a local application rather than having a systemic application. So it's much better to place the drug where you want it to go. I'm just looking, there's a few questions have been repeated, so I'm just looking through here. There's one, so how do you seal over Ledermix to minimise staining in immature teeth? I assume you're talking about Ledermix paste inside the root canal system. It's the same as I mentioned before. Just don't get it in the crown of the tooth. Keep it just in the root. Clean the coronal part of the access cavity out and place your temporary restoration there. If you were referring to Ledermix cement, say in a pulp capping situation, then I'm not concerned about that because it's not going to discolour in an area that's going to show when you think about the anatomy of the tubules. Someone has asked, is Ledermix TGA approved? Yes, absolutely it is. It wouldn't be on the market if it wasn't. Another one, can we use Ledermix as a base where the decay is extremely close to the pulp and no exposure? Absolutely yes. I think that's an ideal material to use in that situation. So effectively what you're doing there is an indirect pulp cap. Someone has asked, is it correct to say Ledermix paste has superior anti-inflammatory properties compared to Odonto paste? It's difficult to answer that because there hasn't been a comparative study, so I really can't say any more than that. But we do know the way Ledermix works. Odonto paste may work similarly, but we just don't have any evidence to say whether it does or not. Is it recommended for pulpotomy compared to other medication? There I assume you mean Ledermix cement. Well, certainly I would recommend it for a pulpotomy compared to other medication. As I said before, we could do Ledermix cement, we could use calcium hydroxide, we could use one of the bioceramics, MTA, biodentine and so on. Any of those materials can work, but my preference would be Ledermix cement. I think we've come to the end of the questions there. I see there's still a lot of people listening. I thank you for your attention, and I hope this session has been useful to you all, and I wish you all a good night. Thank you.